Hi, I'm Emma, and I worked with Belle, Alexandra, and Maya on our data science clinic project with the International Rescue Committee. The IRC works to aid people impacted by humanitarian crises, and our project is working to decrease the default rate for patients in the IRC's Mali childhood malnutrition treatment programs. Defaulting means that a patient fails to complete the treatment process, which occurs when they miss 2 appointments. Defaultment is important to predict because if clinic workers can identify patients at high risk for defaultment, they can provide these children with additional support to ensure they receive continued care and reach a healthy weight. The goal of our project is to create a predictive model for treatment default that meets the requirements of maximizing the percentage of true defaulters that were predicted as defaulted. We restricted the proportion of defaults that are predicted by the model to 20%, since the IRC has limited resources to actually target patients at risk of default, and because of that, they need to ensure the proportion of predicted defaulters is restricted to be compatible with available resources. One of our project's initial challenges was finding valid village coordinates and valid distances between the village and health facility. This was due to issues with the provided locations and unstandardized village names. While the provided dataset was quite large, once we filtered for feasible distance, we were left with a bit under 12,000 patient records and 22 features for our main model, which considers admission data only. Here's an example of a fabricated entry from the dataset. As you can see, there's information on the distance between the village a patient lives in and the health facility they attended, as well as the health data taken at the first admission visit, as well as the second visit, which is called the follow-up. Beneath this table, there's also a map of the village and health center coordinates we originally received. As you can see, not all of these are correct and some aren't even in Mali. This graph shows the distances within Mali before filtering. We filtered the dataset to only include patients who traveled under 30 kilometers from their nearest health center, as traveling up to 600 kilometers certainly isn't accurate. This standard is achieved after conversations with our external mentor and research on the feasibility of travel to health centers.
After data cleaning and model tuning and exploration, our project primarily focused on comparing the results of logistic and lasso regression, XGBoost, and CatBoost models. Our final deliverable was the optimal model amongst these categories for accomplishing our goals, and we prioritized our model trained on the admission data at the request of the IRC. We additionally trained all of our models on data from the first follow-up visit for the IRC to rerun the model to assess patients predicted to default at that point, also at the organization's request. The three primary metrics we used to evaluate our models were recall, precision, and the F1 score. Recall is defined as the percentage of true defaulters that were predicted as defaulted by the model. Precision is the percentage of predicted defaulters by the model who actually defaulted, and the F1 score is a metric which combines the recall and precision scores using the formula that you see at the bottom of this slide. Our goal was to maximize recall while optimizing the values of all three metrics. Our training process began with our clean dataset, which we split into 80% training and 20% test data. In other words, we train our model on 80% of the data while reserving the additional 20% for testing the model's ability to predict on unseen data. We calculated evaluation metrics for both the training and testing sets in order to compare our models to each other. In addition to the metrics mentioned on the previous slide, we calculated the difference between the F1 scores for the training and testing sets to determine how well our model generalized to unseen data, with a low F1 score difference indicating good generalization performance. We'll begin by presenting our admission-only models. Logistic and lasso regression models were evaluated using consistent threshold standards and various penalty values, performing relatively similarly in comparison overall. While both are linear models, logistic regression is tailored for predicting binary values, whereas lasso regression is traditionally tailored for continuous predictions and also reduces the influence of less significant variables. The optimal model in this category was a logistic regression model with lasso regularization. This process enhanced feature selection by penalizing less important coefficients and accounting for prior relationships between predictor variables, which improved interpretability. Additionally, the model balanced class weights to address the dataset's unequal distribution of defaulted and non-defaulted patients.
XGBoost famously works well for classification problems, so we considered this model next. XGBoost is an ensemble learning method which utilizes gradient boosting decision trees. and our initial XGBoost models seem promising. However, if the decision trees become too deep, or if there are a large number of trees, this quickly causes the model to perform much more poorly on the test data as opposed to the training data. Due to the relatively small number of predictors, the large class imbalance between defaulters and non-defaulters, and a relatively small training set, our XGBoost models could not generalize well to unseen data despite efforts to mitigate this issue through hyperparameter tuning. As such, we researched to find a model that worked similarly to XGBoost but had more robust mechanisms for mitigating the issue of not generalizing well to test data. We ended up using an algorithm called CatBoost. CatBoost works like XGBoost but applies a permutation method to the classical algorithm. Like in the logistic and MATLASO models, and also in the XGBoost model, CatBoost allows for handling an unequal number of defaults and non-defaults using weights for each class. Additionally, it permutes or reorders the categorical features and trains the model on one subset of the data, while calculating update metrics on another. This helps the model generalize better to test data. There's still room for improvement in our model, so we plan to work on fine-tuning it next quarter. Here's a summary chart of our admission-only models. Our priority was optimizing recall while generalizing well to the test set, so we wanted to minimize the F1 score difference between training and test data. We chose CatBoost as our best model with a recall of 42% and F1 score difference of 0.05. This means that 42% of the defaulting patients in the test data were correctly predicted as defaulting by our model. On the other hand, the precision value shows that only 15% of predicted defaults were true defaults. This is one area for future improvement. Note also that the recall could have been higher, but limiting the number of predicted defaults also limited the recall. These models include both the admission data from the earlier models and data from the first follow-up after admission. As you can see, the recall value for CatBoost was increased from the admission-only model and is still slightly higher than the logistic and XGBoost model recall scores. The F1 score difference for CatBoost shows that while it generalizes better to the test data than XGBoost, the model would benefit from it being minimized further. As you can see by the logistic model's even lower F1 score, this model generalizes even better than CatBoost. But it comes with a steep trade-off in recall, as the logistic model's recall is much lower than CatBoost's. In the case of models including follow-up data, additional fine-tuning is necessary before determining the best model.
We hope to use a tool that could select the most important features to optimize how well our prediction model worked. This method, known as SHAP, helps us understand the why behind our model's predictions by assigning each feature a value that tells us whether a feature increases, indicated as a positive value, or decreases, indicated as a negative value, the predicted outcome of our model. Looking at feature analysis, the figure to the left shows an aggregate of our SHAP values. These are absolute values showing just generally how features impact the model. The figure to the right shows whether or not that value increases or decreases the model's prediction. Unfortunately, we found that the tool was generally less informative because of how small our data set ended up being. There are very few columns, and because of this, the SHAP model used all of the columns to predict and capture the models of the feature importance. Therefore, SHAP was not accurate for feature importance because the model was not well trained with the small data size. Although we were aware of the problem with this tool, we wanted to explore how well we could combine this feature selection with an XGBoost model. In the next slide, we see the confusion matrix representing that model. Generally, this model struggled with generalizing well to the dataset, and it was just too small of a dataset to accurately select significant features. Moving on to the limitations of our study, we spoke to our external mentor, Zachary, who suggested we explore the relationship between defaulting patients and year. We were asked to explore if several years of data could be used to predict the defaulting nature of another year. Therefore, we tested the performance of the model on different years, but found it to be highly non-uniform. In 2023, we found that with only 2 months of data, it had a far higher defaulting rate than any other year. That period of time had a defaulting rate of 14%, whereas the amount of defaulters across all the years in the entirety of the dataset was 7%. We found that the data was severely imbalanced, and for that reason, we believe that the year could not be used as a predictor unless that imbalance is dealt with. Other major limitations that we found had to do with data irregularities, specifically that of village coordinates. This was a major obstacle to our project as we explored location coordinates that were actually found outside of Mali itself, and we had to drop much of the data frame because of this. In terms of next steps, we believe that in mitigating some of the limitations we just discussed, we could try to increase the amount of data that our model is trained on via new data from the IRC. We spoke to the IRC and they're working on finding coordinate locations for some of the data that was dropped. We are also looking to examine the following question. Can we include public data to help improve the model? For example, does weather or civil conflict increase the rate of default in certain regions? We are hoping to use this question as a guide for future research. Thank you for your time.